Students, you should have your notes for Lecture 4, which is the test of the renal system. And we will start with a review. So this is a CBC, and a CBC includes that information on white blood cells. This one does have a differential. It won't always, but it's very common that your CBC would also have a differential. We've got the red blood cell. We've got information about the red blood cells. We said these things were the red blood cell indices. The thing that's not on this laboratory test is the hematocrit. It just has the hemoglobin, so you would have to estimate that. Let's review then. We look at white blood cells to determine if there's infection or inflammation. You can see what they're using for a normal range here, and this is for an infant. So they've used a higher normal range. For an adult, we use about 5 to 10,000. They expect that you know, they haven't put the labels on here, they expect that you know, this one's 10,000, platelets, 100,000s, red blood cells, millions, 5.5 million to 8.5 million. So let's look at the white blood cells then. There is evidence of inflammation because the white blood cell count is elevated above normal. The good news is, after 1 week, those levels are starting to come back down to the normal range, at least when we look at the total white blood cell count. However, that differential can let us see information, and if you look at the way they're reporting their differential, they're saying we're giving you the percentage number first and the actual cell number second. So this is 68% of those 17,400 white blood cells. So if I did 0.68, make this a decimal instead of a percent, I would come up with 12,512. Then they give me the normals over here. It should be 60 to 77% is normal. Remember, neutrophils were the most common type of white blood cell. Lymphocytes were next. And we look at what's going on with our differential then. So we have a mature neutrophil count for this first test, that the percentage is within its normal range, but the actual cell number is not. So do you see the cell numbers over here? I wouldn't get too caught up in that, but we already saw on our total white blood cell count we were already suspicious for inflammation or infection because it was elevated. The next thing we do, this does concern us, is you have been, your neutrophils have actually increased instead of decreased. They are within their normal range, but we seem to have a lot of those neutrophils. This is not a right shift, because it's not an increase above normal in those neutrophils. And I had a good student question on, I thought it was segs and bands, and it is, except segs are commonly just called neutrophils or mature neutrophils. The bands, we looked for evidence of a left shift, and a left shift was when the band neutrophils are above their normal range. These are within the normal range. These are within the normal range. And somebody might say, well, of course we'd expect this mature neutrophil count to increase from here to here because these bands grew up. These 3% bands would have grown up a long time ago. Those bands grow up in a matter of hours. And so the good news is it doesn't look like the patient's bone marrow is seeing a need, to produce more of those. The lymphocyte count, again, we're getting the percentage in front, and they're telling us the normal percentage is 12 to 30%. This one was in its normal range. Again, we've kind of got that little bit of a slight increase in the number of cells. There are people who will say when you're given the option of looking at the percents on the differential or looking at the actual numbers, there are people who say choose to look at the numbers, and this may be an explanation of why. Your percentage may just be at the high end of normal, but your cell count shows that you're over that. And I think probably that's a better indication. You're doing just a mathematical equation, so it seems like it wouldn't be that big of a deal. But if this is on the high end of normal or on the low end of normal, those cell counts may give us a better picture of, is there something increased or decreased. So monocytes, that's the primary one that's abnormal, is look at these monocytes that are very elevated. So we had an increased total white blood cell count, which indicates their inflammation or infection. The primary defect we're identifying in the differential is an increased monocyte count, and if you remember back to lecture 1, monocytes typically increase when we have a fungal infection. That's not the only thing, and to review those quickly, it was neutrophils, the bands and the segs usually elevate when there's a bacterial infection. Lymphocytes most commonly elevate when there's a viral infection. Monocytes elevate when there's a fungal infection. And neutrophils ultimately, because they're the most common type of white blood cell, they're going to help protect us from all types of infections. But a fungal infection, it could be, you actually can get fungal infections in your bloodstream. You can get fungal infections in your mouth like candidiasis. Thrush is the layperson's name for that disease or condition. You can have a fungal infection, probably one between your toes like an athlete's foot would not cause this elevation in monocytes this way. So next we move to the red blood cell count, and we have our normal range over here, so we can see that our red blood cell count is within its normal range. However, we know to look at this red blood cell indices, because just like the total white blood cell count may or may not say there's a problem, your differential gives you more information about that white blood cell picture. Well, this gives you more information about your red blood cell picture, these red blood cell indices. So let's see how they compare to normal. We have a normal, we have a slightly elevated. So I go back and I remember what this is. Mean cell hemoglobin. And I'm going to go to the next one, and it's elevated too, mean cell hemoglobin concentration. So they're telling us this patient has a normal amount of red blood cells. However, those red blood cells are actually carrying more hemoglobin than they normally would. And that may or may not be a bad thing. Usually we'd be more concerned if it was low, and then that might be due to an iron deficiency. Remember we talked about hypochromic anemia, where if you don't have enough iron, which is the main component of that heme in hemoglobin, then your red blood cells won't be the right size. But as you can imagine, if our red blood cells become larger, the size of them wasn't exactly larger, but they are carrying more hemoglobin. So we would just monitor that. Our platelet count, we come down here and we are concerned about platelets because they help with hemostasis, the ability to stop bleeding. Somebody with a low platelet count would be not a good candidate for surgery. They wouldn't be a good candidate for a procedure that would include biopsies or something like that because their risk of bleeding is higher. Remember, platelets were one of the first processes in that hemostasis. There was that little bit of vasoconstriction. Platelets were attracted to the area. They formed that platelet plug. So this person does look like they have a good ability to stop bleeding if they started. So overall, not some alarming things, but probably this monocyte level would indicate that we need to do some follow-up. And the good news for most of them were the patient improved, except with this one, it looks like we may not have taken care of that infection sufficiently. Okay, next slide then. This one deals with your lecture last week on hemostasis. So why might we order daily clotting tests for a patient on Coumadin? I want you to think about that and see if you could answer it. It's real common in clinical that we see that done. And the most common time we would see that is the daily test would be if we just put that person on Coumadin. Normally, once you're on your Coumadin, and you've been fairly stable on your INR levels, we could drag you out to where you're only going to your pro-time clinic. And so I've answered the next question. Remember, you could do the rule of 10. I count how many letters are in the medication, and Coumadin and warfarin were both 8 letters. That leaves me 2 left over, and that helps me remember that the correct test of hemostasis for a patient on Coumadin is a PT, and it would be extremely common that if you're having PT tests done that you're also having those INR levels done. And those INR levels are going to give us an indication of how long it takes you to stop bleeding compared to a normal person. All right, today we're going to look at tests of the renal system, and to do that, let's start with a really quick review. So most of us have 2 kidneys. Believe it or not, actually, if we had 3 people in a room, there's a good likelihood that one of those people would actually have 3 kidneys. So it's fairly common that there's a fairly significant portion of the population that has 3 kidneys. And that is something that normally you're not even aware of until maybe you've had some sort of issue where they've done a procedure and done an ultrasound or a CAT scan to look at your kidneys. In most cases, one of those kidneys will just be tiny and it may not do much. Alright, so normally we have 2 kidneys. Those kidneys each have a ureter. The kidney's job is to filter fluid, to keep certain fluids in the bloodstream to help us keep our blood pressure. It's to get rid of waste products through the ureters into the bladder. And then this one shows a female. They have a short urethra. Males have a longer urethra. And there's a sphincter that helps us so that we have good bladder tone. And we can evacuate that bladder. So the things that we'll talk about will be evaluating the function of the kidney. There will be things that we do to evaluate the structure of the kidney, the size of it. So the size, I bet you can imagine, we're looking at how large your kidneys are. Smaller kidneys might indicate that your kidneys are not working effectively, and there's a condition called renal failure. Bigger kidneys could indicate a problem too. The kidneys are in a capsule of tissue, and that could, I guess, a lining. That lining could become filled with blood, or it could become filled with fluid, so we might have someone who has cystic kidneys and it makes their kidneys larger. The other thing we want to watch about is or monitor is how well the kidneys work. And so we'll talk about some tests that look at size of these organs, and we'll talk about some that will look at what do they do, how are the kidneys filtering. If you'll face forward, so this person's facing as you look at your screen, you're looking at their back. If you'll place your hands on your waist, and you're going to rest your thumbs on your hips. So I'm going to face my thumbs forward. I'm going to have my fingers then on my back, and my hands are resting on my hips, and where my fingers are covering is called the flank area. So this kind of lower part of your back, and if you feel with your fingers, you'll feel those bottom portions of your rib cage, is where the kidneys are. So this area is called the flank. If a patient comes in with flank pain, that's something that's suspicious for kidney involvement. So as you look at your notes for this week, it talks about what are some of those signs and symptoms of urinary system dysfunction. So if I had hematuria, which is blood in my urine, that's not normal. I could have blood in my urine and it may not turn my urine red. And so I can't just go by color alone. If it's more at the microscopic level that there's portions of red blood cells that have been broken down that are in my urine, I may not actually see the red color. Frequent urination and painful urination. So dysuria, difficult urination. Polyuria, I'm making lots of urine. And a condition that causes you to make lots of urine could be a bladder infection, except with that you usually have frequent urination but in small amounts. If you're really producing lots of urination, we worry about diabetes. So we'll have a whole lecture coming up on diabetes, and we'll talk about why those patients make a lot of urine. The other things that it mentions in your notes is that flank pain, and typically flank pain is associated with kidney stones. So it's pretty unlikely I'd pass stones from both kidneys. It's more likely then that if a patient comes in and they have bilateral flank pain, we start thinking about their back. If they come in with unilateral, one-sided flank pain, then that's more suspect for kidneys. And that pain is described as intense pain, almost like a hot knife being jabbed into you. The other thing that could happen is if your kidneys are involved, a lot of times that pain may be radiated, and it mentions in your note that pain may radiate to the abdomen or leg. So somebody may come in and we think it's their leg or something with their abdomen, when really it ends up being the kidneys. So we've talked about these terms then: hematuria, the blood in the urine; dysuria, the fancy name for difficult urination. I mentioned polyuria, excess urine production, and pain in the renal area. You'll see a doctor, or maybe you've had a doctor kind of pound on your back area, and he's causing a vibration to see if there's pain in your kidney area. So tests of the urinary system that we'll be talking about today, we'll talk about a test called BUN and creatinine. Those will be the next things in your notes. We'll look at some procedures we could do, a pyelogram, cystoscopy, so we'll use a scope to look at how well the bladder is working in this case. And we'll look at some other procedures. We'll end with a complete urinalysis, an examination of what that consists of. So, a very common test done in patients who are admitted to the hospital, or if you have a physical done as part of work and it includes blood work, would be a renal profile. We want to see how well your kidneys are working. So we're not just going to look at how much urine you produce. We want to know are your kidneys doing their job, meaning are they able to get rid of the waste products that they should. So the renal profile consists of two tests that I have never seen them just done separately. They're done together. They do a blood urea nitrogen and a creatinine. This, as the name implies, blood urea nitrogen, we're going to take a sample of your blood. We're going to look at the levels of these waste products, and we're going to use those to evaluate how well your kidneys are working, or if you're a patient with a condition like diabetes that we know causes kidney problems, there are medications that can damage kidneys. And you say, well, I wonder why we'd give those to patients, but we have to do a risk-benefit ratio sometimes. We know that there are risks with a drug, but we believe that the benefits outweigh those risks. So patients who are on dialysis, they'll monitor their BUN and creatinine to see how frequently they need to come in for care. The type of solution that they put in that dialysis machine is determined by their BUN and creatinine levels. If you came in with kind of those non-specific complaints like flank pain, or maybe occasionally I see blood in my urine, or as I mentioned, if you had a routine physical that included blood work, and if there are drugs we know are nephrotoxic, so when we talk about nephro or renal, we're talking about the kidney system. If we knew we had a drug that we're giving you, an example could be contrast media that's used as part of an X-ray procedure. Some of those are nephrotoxic. And again, it's that risk-benefit ratio. We believe that the information we get from the test is worth that small amount of risk to your kidneys. But if you already had kidneys that weren't working very well, we would maybe avoid giving you those drugs. We might say, we can't do that procedure, or we do it a different way. So the first test on your notes is a blood urea nitrogen. And even though it mentions urea, and I bet all of you think urine, and that is correct, this is going to be the amount of urea, which is the waste product there is nitrogen. We're going to look at the amount of nitrogen that's in your blood. And urea is produced when protein breaks down. It's a waste product the kidneys should get rid of. And so if you could picture that your kidneys are a filtering station. So as urea comes by in your bloodstream, the kidneys should filter that out. So what would cause those levels to increase? Well, they would increase if the body's producing more urea. In other words, more protein is being broken down by me or my body. And they would also increase when I'm unable to get rid of that waste product like I should. So what if something's wrong with one of my kidneys? It's blocked by a stone. The blood levels of urea would start to increase. And azotemia, and I was on patient rounds yesterday and we had several patients with azotemia. Azotemia means an increased BUN. So why would those patients have azotemia? They might have it because they had seizures, and when you have seizures, you break down protein. If you have disease states that cause muscle to start to break down. If you think of where you have protein in your body, protein is found a lot in muscle. It's found in meat, in tissue. So azotemia, by telling us that in rounds, they were telling us without looking at the BUN that the BUN was elevated. And the way I remember this is I put A, B, C order with these tests. I do azotemia, I then do BUN, and the C would be creatinine. And so that helps me remember A comes before B. Azotemia is an increased BUN. The next thing is look at this normal range for BUN. And look at this range for creatinine. Let me go here quickly. See this range for creatinine? So the next thing is sometimes they just tell you the levels and they expect that you'll know which one is the BUN and which one is the creatinine. So can you see that the creatinine is always in decimals, or it's a very small number compared to the BUN, which is larger? So if they give you two numbers, by putting them in A, B, C order, it helps me remember B comes before C, and so that helps me remember that BUN is the higher of those two numbers. So azotemia is an increased BUN. BUN levels are higher than creatinine levels, always. All right, next thing. Let's do some application then. What if somebody had a blockage of a renal tubule? So what if my kidney is working, it's trying to work, but downstream there's a blockage? That would most commonly be a stone, but it could also be a tumor. Doesn't make sense if I have only one kidney really able to work that my BUN levels would start to go up. What do you think would happen if I eat a high protein diet? So let's say I'm trying to lose weight and I've done a little bit of research, and there is some data that shows that switching to lower carbs and normal or higher protein levels. So I eat a lot of eggs, I eat a lot of fish, I eat a lot of meat. What do you think happens to my BUN levels? They do go up when I eat a high protein diet. And that makes sense. We said your BUN could increase when there's problems with the system, with a blockage in your kidneys, or your kidney isn't working, or kidneys are not working. It could also happen because there's increased amount of waste product, that you ate a lot of protein. What do you think would happen when you're malnourished? So I want you to think about those pictures you've seen of those children, especially with the big, large bellies, and you think, oh, they look like they're fat, at least from their belly, but their body is wasting away. Do you remember that your body likes to burn carbohydrates first? Then it burns protein, then it burns fat. So that's the frustrating piece of somebody trying to lose weight. And you hear of people who say, well, I'm just not eating. And we know that if you starve yourself, essentially, your body will burn protein instead of burning fat. It burns fat last. So if I'm malnourished, what's my body using for that energy? It's breaking down muscle. It's breaking down protein. So my BUN levels would go up. What if I have overhydration? So because we're taking a sample of blood, and we've already looked at that issue when we discussed white blood cells and red blood cells, that we have to look at how hydrated a patient is. If a person is overhydrated, does it make sense that if I take that sample of blood, it could look like the BUN level is decreased compared to normal? So when I do any samples of blood, I have to always think back, is this patient overhydrated or underhydrated, dehydrated? Creatinine is measured on a blood sample, and the creatinine is a waste product of muscle metabolism. And what I mean by that, I bet some of you have heard of a product called creatine. Well, in our bodies, we have creatine. We make it naturally, and creatine converts food into energy. It's found in our bloodstream, and it's found in our muscles. And so I have this note: if there's muscle metabolism, if our muscles have done a lot of work, if you are maybe working out, you hear that you tear down muscle to rebuild muscle. And so if I'm maybe a weightlifter and I did a whole bunch of heavy weightlifting and I feel really sore the next morning, I probably have quite a bit of creatine in my system. I've broken down that muscle. And when that muscle breaks down, it releases that creatine, and creatine converts into creatinine. Similarly, there's a product called creatine that weight builders or bodybuilders or somebody trying to put muscle on will take. Well, that's a good thing if you're taking the recommended amount, and if you're drinking lots of water to go with it, it does increase muscle size. So it can make people stronger, essentially. It can make them a little more bulked up. But they have to be careful because they are dealing with something that is already found in our bodies, so too much could be a bad thing, and they have to be careful that they're making sure they drink a lot of fluids with that, or it can become a negative. All right, with creatine then, it is a more sensitive indicator of kidney disease than BUN. So what does that mean? Well, yesterday I took care of a patient who had an increased BUN, but their creatinine was normal. So it was kind of a heads up to say, watch what's going on, and each day they would repeat that BUN and creatinine test. But just because the BUN is elevated, that could be just because of protein metabolism. The creatinine, if it starts to go up, then we do basically know that the kidneys are involved. That could mean that there's just increased amounts of waste products, or the kidneys are not able to filter the blood as they should. So we're more concerned when the creatinine level goes up, but both the BUN and creatinine are indicators of kidney function. Excuse me. What do you think happens then to creatinine levels if I eat a lot of meat? And meat is muscle. So creatinine levels can be affected a little bit by consumption of meat. BUN is more affected by that. What do you think would happen, though, if I just ran a marathon? So think of, even if I'm a trained athlete, that's put a lot of stress on my body. Can you imagine that some of those muscles have been damaged? And when those muscles are damaged, they would release waste products into the bloodstream. And do you think your kidneys would have had enough time to filter that out yet? So remember we said that lab tests could be affected by exercise. This would be something if we did creatinine levels on someone just after they finished a marathon. Their BUN and creatinine levels could be elevated, but we would say, oh, I'll bet it's because their body just went through a lot of stress, and if they drink fluids and their kidneys are healthy, that should be cleared out pretty quickly. What if I take the supplement creatine? What do you think happens to my creatinine levels? Well, creatine converts to creatinine, and so my levels have to go up. And so there is a caution on the supplement creatine that says, you know, if you have kidney damage, don't use this product. And that would be the takeaway message for someone who's taking this that has healthy kidneys, though. That's why that warning on drinking sufficient fluids is important too. They want to help with the kidneys being able to get rid of that waste product. Okay, the next thing. What if we have someone who has kidney stones? And normally our body will get rid of waste products like calcium. If you have a diet that's high in oxalates, and that is these foods right here, poultry, meat, and fish do that. But I also want to warn you, the other thing that's high in oxalate is dark colored soda. So if you drink a lot of Dr. Pepper, any of those cola drinks that are dark, I believe root beer fits into the same category, and the key is that darkness. Dark soda drinks are high in oxalates, and so you're more likely to form kidney stones if you consume a lot of these products, or if you're consuming a lot of dark soda. If you're a patient with inflammatory bowel disease and certain types of cancer or thyroid disease, you produce a lot of calcium in your blood. And in fact, that's one test we might do to kind of screen for cancer, as a blood calcium test. Or we might see the symptoms before we've diagnosed the cancer. So why could somebody form kidney stones then? It's usually that they've had excess consumption of something, or they have a body system that's producing excess. The reason we talk about calcium and oxalate is those are things known to form crystals, and those crystals can start to form together and form stones. So kidney stones could be made up of phosphate, magnesium, ammonia. Most commonly they're made of calcium, and so we can see them on X-ray because we can see bones on X-ray, and bones are made of calcium. So because most kidney stones are made of calcium, about 70% of them, we might just start with an X-ray that shows us your kidneys. Okay, takeaway message from this slide. If you consume a lot of dark sodas, be aware that one of the things that could happen to you is kidney stones. A renal ultrasound could be a place to start if we think you're having kidney problems. So we diagnosed that by you coming in complaining of flank pain, or you said, I have blood in my urine, and we start to suspect that maybe the kidneys are involved. The doctor taps over your back area where the kidneys are located and you have pain. We have someone who played in a football game and they know that they took a hit to the flank area and then started producing some urine that had blood in it. Can you see that by looking at kind of these fuzzy images we get from ultrasound, we can see the size of the kidney, and they can measure that and compare it to normal. They can look at the density of the kidney. So that kidney should be composed of fairly solid tissue. Can you see the amount of black in this kidney? But especially here, can you see those little pockets? And on ultrasound, things that are more black are less dense. So air or fluid is less dense than tissue is. Tissue would be more white. So the ultrasound could tell us something about the density and the shape of the kidney. A KUB radiograph, and what it stands for is K is for kidney, U is for ureter, and B is for bladder. And I'm jumping around just a little bit in your notes. This is on page 2, a KUB radiograph. And it's essentially just doing a plain film, and plain we mean P-L-A-I-N. That means not giving you any kind of contrast to make things show up. So here's a normal KUB film, and it's going to go from about just above the level of your belly button. So if you can find that area on you, and it's going to go down below your pelvis, so kind of at the bottom, I guess, of your crotch area. They're going to place an x-ray plate and take a picture. So here's normal, and we do see your pelvic bones. We see the bottom of your backbone. You can see your tailbone. We can see the bottom of your rib cage, and we know that right in here was where your kidneys would be. So on x-rays, we don't see soft tissue very well. We can see things that are really dense. Bone. We can see differences in densities. So I can see that this is less dense. Things that are solid, that are more dense, are going to be white, just like on an ultrasound. Things that are air-filled or fluid-filled are going to be dark. Well, what do you have here that's a big pouch or an organ that's going to catch a lot of fluid? Well, this is the bladder. So can you see the bladder here and the bladder here? And partly it's orienting yourself to where things would be. What do you think would be in this area of your belly that would have a mixture of more solid and more liquid? Well, these are your intestines, and so you have air and fecal matter, or depending on which portion of the bowel we're looking at. So now look at this one, and I've labeled it renal stone. Can you see the stone? And you remember that about 70% of kidney stones were made of calcium, and we can see calcium on just an x-ray. So if you came in with possible kidney stones, we might just start with a KUB radiograph. A KUB could show us a bladder stone. So could you imagine having a stone that large in your bladder? And this person would actually feel that move. So they might notice if you have a big enough kidney stone or a big enough bladder stone that when you move, when you lay on your side or when you lay on your back, you could actually feel that thing kind of roll around in you. My father had a large kidney stone, and he could feel his move around in his kidneys. My dad has had kidney stones a couple of times. The first time, the physician attributed it to the fact that he would take Tums, the antacid pill, and he would get the giant-sized bottle and he would drink them. So he was taking way higher than the normal amount of antacid, and do you remember that antacids have calcium in them? And so he caused his kidney stones that time. Well, the second time, guess what he drank a lot of? He drank a lot of dark-colored soda, and it was diet soda. He would drink Diet Coke, but he ended up with oxalate kidney stones this time because of those dark sodas. And his stone was so large that they were unable to break it down. That's one way to get these stones out, is to hit them with a machine called lithotripsy. And it would be kind of like a jackhammer that would break that stone into smaller pieces so that you could pass it either through the ureters, if they're up here in the kidneys, or through the urethra, if you here in the case of a bladder stone. They were unable to do that, and so they actually had to make a hole through his back, put a tube from his back to his kidney, and then kind of bring that out in pieces manually. Not fun, huh? How else could we see organs that are soft then? If we can't see soft tissue on an x-ray, other than just the outlines of them, what if we did an x-ray, a computerized tomography, CT, and I have this information. I was looking at your notes to see if I actually had included much with this one. We'll talk about CAT scans and MRIs kind of throughout the semester, and so I don't see a specific piece in your notes on this. But when I look at the size of an organ, do you see how I can see that now? Well, because this is a soft tissue, what we've had to do is give the person some contrast, some dye. And that would allow us to see these structures easier. So can you see bits of intestine? And when you look at an x-ray, it's always as if the person is facing you. Well, this person laid down. And so as they laid down, you're looking at their backbone here. You can see that they have some subcutaneous tissue here on their back. We're coming up. Here's some of those ribs. We're just catching pieces of ribs. And we're in that flank area seeing the kidneys. We're seeing little bits of the liver. And so can you remember which side your liver is on? It's on your right side. So the person laid down, and it was as if they were standing up facing you, and then they laid down. So sometimes they'll be labeled. You can see an R and an L here. But when we look at a CAT scan, which is an x-ray, or we look at an x-ray, it's always as if the person was facing you. And in this case, when they're laying down, they faced you, and then they laid down. So we're looking from their feet up. This is their right side, left side. We can see intestines. We can see a blood vessel that runs right along the backbone, and that's the aorta. That's what your aorta looks like at this level. Blood vessels would come off the aorta and go to the kidneys. So we can kind of see pieces of that happening there. So pretty fascinating pictures. Now, is this telling me if your kidneys are working, though? Does the ultrasound tell me if your kidneys are working? These pictures tell me the size and the shape. They could look for stones. They could look for abnormal densities, like a tumor that's making it more solid. But they don't tell me about how it's functioning. Now we're moving to a different procedure called MRI, and a magnetic resonance imaging procedure. And with MRI, we're using a magnet, a large magnet, to take pictures of your body. And we're going to talk about MRI throughout the semester. So if we want to look at an organ, if we want to look at muscles, if we want to look at tendons and nerves, those things that are soft tissue, a lot of times a physician may choose to order an MRI rather than a CAT scan or an X-ray with contrast media, Can you see the detail of the kidneys? So we can see the ureter coming off here. Isn't that amazing, the detail that you can see? This is of a person who's a little more atrophied. Makes it a little smaller, more solid. This one, the person sliced like a loaf of bread. This one, they're sliced right down through their body from front to back. So with MRI, we're using a magnet. With ultrasound, like the name implies, we're using ultrasound. With CAT scan or X-ray, we're using X-rays. And there is a concern about long-term exposure to X-ray. MRI, because it uses a magnet. If you have a pacemaker, you can't have an MRI. If you have metal in your body, that's magnetic. If you're a welder and you've been around iron and maybe some of that has migrated into your body, if you know that you were shot with something that is magnetic, most of our metals that we surgically implant in people now are not magnetic. And the reason for that is so that they would still be able to undergo an MRI. Ultrasound, as far as we know, using ultrasound has no long-term effects or dangers associated with it. Okay, IVP. This is back on page 1 of your notes. We've talked about tests that look at the structure, the shape of your kidneys. We haven't really looked at tests that look at how well the kidneys function. We talked about BUN and creatinine. We could see if they're getting rid of waste products. But what if we actually want to see them do their job? So if you read the information on the IVP, it reminds you that soft tissues don't show up very well on x-rays. So we use contrast media. And an IVP is going to use x-rays. We're going to take the person and intravenously we're going to inject some dye, some contrast that's put into their blood vessel, and we're going to follow that through their kidneys, out into their bladder, and then we could do a voiding where they're urinating. We could take another picture. So this has been a picture that's taken after the patients had this contrast in their bloodstream for a little bit. We're going to take repeated films to kind of look at this over time. But can you see the kidneys actually doing their job then? Could you see the shape of the ureters? And so we could see if there's a narrowed area or a twisted area or if there was a stone there. They're showing you the inside part of the kidney. The kidney should filter that contrast media out like it's a waste product. So this is not a big stone here. This is actually the contrast. This is the same kind of picture like a KUB film. Look at the area they're taking. Here's your bladder, here's your pelvis, here's the bottom of your ribs with those backbones. So a KUB film with the ability to see this dye, that means they're doing an IVP. As you can imagine, there's some risk. That dye can be damaging to the kidneys. Well, this is exactly where this dye is going in this case. But look at the amount of information we can see. We can see those kidneys working. And at least with this view, it looks like that right kidney is working a little bit better than the left. It's not labeled right and left. You remember, it's as if the person is standing facing you. So right kidney, left kidney. This ureter, it's definitely working because we can see fluid going all the way through it. But do you see that this area looks like it might be a little more narrow than the other portion? Now look at this one. So they say here's a filling defect where all of that kidney should kind of be working and it's not. Look again at this little twist in that ureter. Could you see how maybe that might lend itself more to blockage? And maybe a bigger concern is, how come this kidney's not working? This should look the same on both of these. So here's a person who has a non-functioning kidney, and now they have one that's not starting to not work as effectively as it should. So as you can imagine, that's fairly dangerous. If my kidneys don't work, I'm pretty much going to have to be on dialysis. And that could be even a daily thing that has to happen. So an IVP. So what might an IVP be used for? If we think that you have some sort of mass, maybe we started with an ultrasound and we saw an abnormally dense area on your kidney, and that could be a tumor. We use it to look for bladder abnormalities. It's going to tell us information about how your kidneys are functioning. So this one tells us about kind of the size of the kidney, but it tells us more importantly, is it doing its job? It tells us about the function of the kidney. If somebody had frequent urinary tract infections, if a woman has frequent urinary tract infections, they worry that when they urinate and they have that pain and they push, maybe this infected material that's in the bladder goes back up into the ureters instead of only being able to drain. And as you can imagine, if I had infected fluid here that gets back to the kidneys, the next thing I have is a nephritis, an infection of the kidneys. In a male, if you had urinary infection, it's so rare to have urinary tract infection in a male because your urethra is longer. It's harder for bacteria to get back into the bladder. Remember, urine should be sterile. They would move to an IVP quicker maybe. So IVPs are done if we think you have kidney stones, if you have flank pain and we don't know what's happening with it, if we want to identify where your kidneys are working correctly or not. If you already had kidneys that are kind of borderline unfunction, we may not give you that contrast though. So we might have to do something like an MRI, which would allow us to see the soft tissue. Cystoscopy. Yeah, that's on page 1 in your notes. Anytime we use the word scopy, we're using a scope to look, and cysto refers to the bladder. So this is a procedure where we're going to use a scope to visualize the bladder. To get there, we're going to go through the urethra. So some of these tests don't sound very fun to me, and I'm glad I haven't had a lot of them. This scope is going to let us take biopsy samples. We could use a little pinchers, forceps, or we could use a brush, and we're going to be able to look directly at the bladder and the urethra. So by using the scope, the physician is able to pass some instruments through there. They can directly visualize, and they visualize some tumors here. They could pass an instrument through that scope and take samples of that tissue. Here's what those might look like. So as you can imagine, this could collapse down to go through the scope and then enlarge. It could be used, these are fairly sharp, it could be used to kind of pick up a piece of that tissue and then pull it back through that scope. Sometimes we have procedures that we need to biopsy something. And I guess I should tell you better here too. With this scope procedure, especially in men, the prostate is located where it could push or impinge on that urethra. So the doctor could do procedures through the scope that would make the prostate smaller, like they can use oh, the word is gone to me right now. They could use lasers through that scope and do procedures on the prostate. They could look at whether a prostate is causing problems pushing on the urethra. So they could see why someone's having difficulty urinating and that type of procedure. Okay, now let's do biopsies. There are open biopsies and there are closed biopsy. Both of them we're having to open a hole, so it seems weird that we'd call it closed. But an open biopsy means we've actually gone and made a surgical incision and we're going into that area. We don't have a scope that's small enough to go up into the kidneys or the ureters. We can put one in the urethra and the bladder, but we really don't have scopes that go all the way up to the kidney. And so if we need to get some kidney tissue, we might have to do an open biopsy. I bet you can tell they haven't gotten this through a little tiny scope. They've done a surgical incision to take that. And it mentions in your note the times that we might have to do a kidney biopsy might be to see if you have kidney disease. It might be to tell us information about if you've had a kidney transplant, how well the body is doing at accepting that new kidney. This is called a closed biopsy, or another name, probably a more common one, is called percutaneous biopsy. Percutaneous means through the skin. And you can see this needle, and those can be fairly large in diameter, but it's got a piece that would be almost like you see them take samples from a tree, where you would maybe put a solid needle in and then have a needle that kind of twists and spins to take the inside sample out. So if we do this kind of procedure, a biopsy, we call it closed or percutaneous. So if I had my choice, I'd pick a closed biopsy. But the advantages are with an open biopsy, they can see exactly where they're taking the sample from. How are you going to decide, if you do a percutaneous biopsy, how to place that needle correctly? We're going to use ultrasound, or we're going to use a procedure called fluoroscopy, which is a moving X-ray. Sometimes they use CAT scan to guide the needle, but that's a fairly expensive use of CAT scan. So with fluoroscopy or ultrasound, they would have it set up at the same time they're doing this biopsy procedure. So maybe they see a density in this area, they'd try and guide the needle into that area. If we do it through the skin using just a needle, we call it percutaneous. If we do a surgical incision so that we can get a scope or something in there, that may be called an open biopsy. Okay, now we move to some procedures about urine. So I'm at the top of page 2, and it talks about a urine toxicology, and it lists some of the medications or over-the-counter medications or non-prescription medications or illegal drugs that could be screened for when we test your urine. So a lot of us are familiar with this, that they do drug testing when I start employment. That would be one use. It really is a urine toxicology. In the hospital we use this commonly If someone's been involved in an accident, especially if you're a commercial driver, it's mandatory that we would obtain urine and screen it for drugs. If you were found unconscious at your home and we don't know what's happened to you, we'd do a urine toxicology to see if drugs might be the explanation for why you were found unconscious. As you can imagine, a little child, what if they got into medication and someone finds them unconscious and they're not sure what happened? A urine toxicology might be helpful. So in someone who is found unconscious and we really don't know an obvious cause, if someone caused an accident or we're not sure why an accident resulted, we might obtain a urine toxicology. They do obtain these for drug screening as part of employment. I bet most of you are familiar with the fact that we can screen for illegal drugs, but a lot of times they are also looking at the use of legal drugs. And so it may be to see if you're compliant. It might be part of a compliance plan. Maybe you're on a medication that you're supposed to take every day, and we can make sure that you are doing that. Okay, a test. What is this film? Is this an IVP or a KUB? Because I can see pelvis, I can see bladder. Because this person's bowel has a lot of air in it, I can see that. And this may be the reason for that air. These are surgical staples. So they've got a pretty big incision that goes almost from the top of their pelvis to the bottom of the rib cage. So we're going to bet that they've done some sort of bowel surgery. And so a KUB film is used for more than just kidney, ureter, and bladder. It tells us about the bowel. But do you see any contrast dye? Do you see those kidneys outlined? Do you see the ureters coming down? Do we see that contrast media in the bladder? No. So that makes this a KUB film. So a KUB film could be used to study the abdomen, even though it technically means kidney, ureter, bladder. It says, get me an x-ray that shows those areas, which would be kind of that lower abdominal. Okay, urinalysis. We'll kind of finish with this piece. We can do a urinalysis using reagent strips. And if you look at page 2 of your notes, the third item there is reagent strip. We can also do a complete urinalysis, which would include two parts, a macroscopic part and a microscopic part. Which do you think this is? Do you think this is a complete urinalysis? Or do you think this is using a reagent strip, or some people call it a dipstick? So if you have a hot tub, you're kind of familiar with how this works. I bet most of you, if you've been to a doctor and you've given a pee sample, you've seen them do this. You're going to match each one of these colors with its best match on those lines. So it's not matched this way. Each of those items is matched going across. And each of these, if we could read the labels clearly, it might say they're looking for ketones, they're looking for blood, they're looking for protein. There's a list of items under the complete urinalysis that could tell us what they're looking for. This test is not as detailed as a complete urinalysis. It's kind of a quick and dirty test. Not dirty meaning fast. So it's a really quick test where a complete urinalysis takes longer to get results back. It's kind of a screening test. If we go to a complete urinalysis, you get a report back that tells you about the macroscopic piece. It tells you about the color of it. So normal color of urine is clear. This person actually had a little bit of light yellow instead of, light red instead of yellow. So your urine should be clear, not cloudy. It should be pale yellow. It's primarily made of water, and the specific gravity of water is 1. So it's water with a little bit of waste product in it. The pH of your urine, we have a normal pH, and if your pH is too low, you're at risk for certain things like kidney stones. If it's too high, you're at risk for certain things like bladder infections, and that's why there really is some benefit in, if you have a bladder infection or frequent bladder infections, using things like cranberry juice. Eggs and oxalates change the pH of your kidneys, and so that, or your urine, and that may put you more at risk for kidney stones for that reason too. Normally you should have no blood in your urine. You shouldn't have any protein in your urine. This person had 4+, And that's the maximum amount they're going to record here. 4 plus means there was a lot of blood. Well, that makes sense. Their urine was light red too. Can you imagine there are other things that could make your urine light red too? If you eat a lot of beets, it could change the color of your urine. There's dyes that could change the color of your urine, and I know that sometimes kids in high school do a thing where they make somebody brownies, not with marijuana in it, but with a dye in the frosting, and so when the person goes to the bathroom, it makes their urine blue or something. Could you imagine if you peed blue, you'd probably be a little bit concerned. So just because your urine's a color doesn't mean you have something wrong with it. Maybe something you've eaten. But I shouldn't have protein in my urine, and the main thing this would be albumin. The kidneys should be saving albumin rather than getting rid of it. Leukocytes, well, I know what those are. Those are white blood cells, and I shouldn't have any of those in my urine. I shouldn't have glucose in my urine. I shouldn't have ketones in my urine. We'll talk more about those when we talk about diabetes. Bilirubin is a waste product. I shouldn't have that in my urine. Urobilinogen is kind of a precursor to bilirubin. Nitrites are released from gram-negative bacteria, and gram-negative bacteria are the most common cause of urinary tract infection. So if I were to give you this report on the test this week and say, does this person have evidence of a urinary tract infection, you'd focus on the nitrites, and they have none. You'd look at white blood cells, and this is just looking for leukocytes. They don't have any. Do they have evidence of trauma? Well, maybe, because they had blood in their urine and they had protein in their urine. So kidney infection could do this, but they don't have evidence of infection. They don't have those things elevated. They just have evidence of trauma, or maybe a kidney stone. A kidney stone could do this. Those stones have sharp edges. I'll show you some pictures in just a minute. Here is another urinalysis report. Let's see if we can figure out what's wrong with this person then. Their appearance was clear. Their color was yellow. Those were normal. Specific gravity is within its normal range. The pH on the upper end of normal, but it's still normal. The protein's negative. Glucose is negative. Ketones. So pretty much they were looking for casts. Here's that microscopic part. White blood cells per high-powered field. Red blood cells per high-powered field. Casts. And I'll show you what those look like. Per low power field, they didn't have anything. So here's a normal urinalysis. A lot of these things should be negative. Do you see how those crystals have sharp edges? And those crystals could join together and make stones. So let's do a case study then. Here's a man who visits his physician. You can see his complaint. So in his back and his side, he has sharp pain. He does say that he ate a lot of animal proteins, meat, cheese, fish. You remember those form oxalate crystals? Normally, I'm not saying don't eat meat, cheese, and fish. I'm saying don't eat these in large quantities all the time. Vary your diet. So they did a urinalysis, and let's see what we'd expect. So there was not evidence of infection here. There weren't white blood cells. His nitrite, that evidence of product produced by gram-negative bacteria, was okay, but he had a large amount of blood and a trace amount of protein. So he does have some damage to his kidneys. Now that could have been medication that damaged it. It could be trauma that damaged it. It could be stones that damaged it. And I'm sorry about this font, but when they did the microscopic analysis, they find a lot of red blood cells per high-powered field. They found a few white blood cells. They found a little bit of bacteria, but for you to have a urinary tract infection, this has to be in the thousands. And they found a few unidentified crystals and epithelial cells. So the kidneys are, the cells to the kidneys, the lining of it are being damaged a little bit. That person was diagnosed with kidney stones. Now we have another one. Here's a child who is getting over a strep infection. So they had strep throat. But instead of getting better, they seem to be getting worse. So they went in with fever, nausea. They're starting to have an infection that involves the kidneys. So if we look here, they had moderate amount of blood in their urine. They didn't have glucose. They did have a large amount of protein, and usually that's albumin. It's not normal to have any protein in your urine. They did have a little bit of leukocyte esterase, and again, that's an indicator of infection. The nitrite was negative. When they looked at the microscopic analysis, they saw granular casts. So one of the things we're worried about is if you get a severe infection in your body and you're on medications that are trying to help you fight that, those medications might damage your kidneys, but that infection might damage your kidneys too. Not by making your kidneys get infected, but by actually causing the lining of your kidneys to be damaged. So glomerular nephritis, the inside lining of the kidneys. This is red blood cells that are making little casts. Casts are like little jello molds, little things that represent the inside of that. So it would never be good to have the inside lining of your kidney be damaged enough that it's starting to have these when they look at your microscopic exam. So that child was in pretty bad shape. Here's white blood cell casts if you had a really bad infection in your inside of your kidney. So usually we have bladder infection and we identify that, but that's why we want to treat those bladder infections so that they don't get to the kidney. Okay, last couple things then. Here is a test that was combined which showed BUN and creatinine. Those are both extremely high. Look at the normals over here. Sometimes we anticipate abnormal laboratory tests. If I had a patient who's diabetic and I know that they've had renal function problems, I would not expect them to have totally normal BUN and creatinine levels. So some patients, their normals are going to be high, and we may kind of establish a different set of normals for them. And I'm not saying that's the case with this patient, but sometimes it is. This would demonstrate a lot of damage to those kidneys or a lot of waste product. The kidneys are not working because the creatinine level's elevated, and it's the better indicator of kidney function. We'd say we probably have renal failure, kidney failure. That starts to affect electrolytes, which we'll talk about next week. Okay, I'll get the quiz posted, and if you have any questions,